Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for joining me today on the second of a series of special episodes looking at policies impacting connected health technologies in healthcare. Joining me for this monthly series is my co-host, Morgan Reed. Morgan is the president of the App Association and is also deeply involved with Connected Health Initiative, or CHI as we call it, which is a coalition of industry stakeholders and partners working to clarify outdated health regulations, incentivize the use of connected health technologies, and ensure an environment in which patients and consumers can see improvement in their health. Morgan, good to be back together.
Jim, it's always good to talk to you.
Well, one thing I want to jump right into it is last week Congress passed this 2022 Omnibus Spending bill. I believe it was actually passed on the Ides of March. So that's a good place to start, policy, regulations, things like that. What are your initial thoughts about it?
Well, the first thing, my first thought is that it almost is late enough to be called one of those better late than never. When you think about it, it's the 2022 Omnibus Spending bill, but we're already a quarter into 2022. I know that scares all of us, but it would be nice if these things moved a little faster so we could all make better decisions a little earlier. I'd say for your audience, couple of key things to note is it expanded the coverage for telehealth services under Centers for Medicare and Medicaid, CMS, to all of those you playing at home. And that was a big win and something I think that was really good from a patient's perspective. The bigger issues that I think that we have to be considering is at the core, it still was a little bit of a kick the can down the road when it comes to telehealth services and some of what we've all been using in the tools that we have been reaching our physicians, and our physicians have been talking to us. What it does is it extended coverage for telehealth services under Medicare and Medicaid for 151 days after the pandemic era public health emergency comes to an end, probably in April. Now, there's a little bit of carefulness here, why I'm being kind of slowing down here on this is, so it's 151 days after the PHE, the public health emergency, comes to an end. But there's another 60 days of wiggle room in there that may or may not happen, and we have to see at what point the PHE is officially announced that it comes to an end. And I mentioned that. Sorry.
Well, no, I just want to say, that extension, I think right now, the public health emergency is set to expire April 16th. And it's almost definitely going to be extended. Some people say 60 days. I've heard some people say 90 days, but some type of extension. But that based on pushback from providers, HHS has promised that if there is an extension or however it goes, they've promised they're going to give at least a 60-day notice before it expires for good, because it affects reimbursement models.
Right. That essentially is our 2 60-day maybes, right? We've got a 60 to 90-day after the April date, and then 151 days, and then another 60 days.
Right.
But that's kind of what we're looking at, and that's where I was going with this kind of 151 plus 90, maybe minus 30 plus 60. And I mention all that because those of us who work in healthcare know that you're making decisions about your providers and your patients that aren't on a 60-day window. You're deciding what products to buy, what clinicians to bring in, how to bring in nurse practitioners, all of that stuff that you have to find reimbursement for. You're looking at that in a 1 year to 5 year window. So I'm really happy that Congress did what they did, but I'm frustrated by the fact that our industry that people depend on for the choices between life and death, that we're having to play footsie with maybe 60, maybe 90, maybe 60 minus 30 plus 150 plus 60, maybe more. And I feel in my heart for every single one of your listeners who works inside of or works as part of a provider service and trying to figure out, what does this mean? Who do I hire? How do I move forward? So that's part of why I mentioned it. So the good news is they did something. I think what all of us would like is a little bit more figuring out what it means in the long term.
Well,
sorry.
I got another question. I'm gonna ask you as we go through this. So you mentioned that the bill provided telehealth extensions. Now, are those extensions related to the parity of allowing reimbursement telehealth versus person-to-person visit? Is it reimbursed?
Right. It does. It also continues to provide something that patients have found really important, which is voice only. So it doesn't get us trapped in this idea that it has to be voice video that's done at a fully qualified health center, that you don't have to go to some kind of facility to do it. It also, importantly, especially during what we've been through, it adds audiology, occupational therapy, physical therapy, and speech pathology to the list of reimbursable telehealth services. So couple of things there. It does mean that it covers more things, and it's been specific in the kinds of things that it covers. And you think about physical therapy as a great example where you might want to put your camera on and have your doctor watch you doing the exercise and saying, no, Mrs. Jones, I need you to stretch a little deeper. Or no, Mrs. Jones, try your foot here. Or great job on what you're doing right now.
Well, Morgan, those things you say it adds, so they previously were not reimbursed for telehealth. So these are new things, right? Well, that's gigantic. That's gigantic.
I agree.
Yeah.
But those are trapped in the 151 plus 60 minus 30 plus 60 at the end. So this is kind of the point. If I'm a practitioner and I'm looking at how do I reach patients who are hard to reach with my physical therapy, I'm looking at this and trying to figure out how to move forward. And then the other part that they really added is over the next year, the Medicare Payment Advisory Commission, the MPAC, will essentially be pulling data in to look at the use of impact on telehealth services on patients and looking at quality of care, really, which we know boils down to the big thing of efficacy and does it actually work? Is it meeting the quality of care that helps patients? So that part's all good. There's a ton of good news in here in that regard, especially as we're coming out of the pandemic and trying to return to figuring out what does the new version of healthcare look like? How do you work with an inpatient visit or an in-hospital visit, but also support patients outside of the hospital and give them the level of service that means that it's reimbursed, that it has the reimbursement that's owed, that's necessary to keep the wheels of healthcare moving.
One thing you mentioned is this federal body that's going to advise this Congress is studying the impact on telehealth, whether it diminishes the quality of care. And I think there's kind of a one-eyed jack in there is some encounters, it doesn't matter if they're telehealth or analog in person. Some should be in person. And we're
MedPAC. Sorry.
No, go ahead.
No, you're exactly right. And that's the thing is that digital medicine is not a replacement for all care. Digital medicine is a yes and. And I think that's a key point you're making. And what we're going to have to look at on quality of care is it's going to be hard to do a true like for like on the comparison of care, because if I went to my doctor's office once a week and my doctor had a level 5 laying on of hands where I sat on the paper, and we had that engagement, one could argue that I might that we might discover things together, my physician and I, that might help me on my quality of care. But realistically, I don't have time as a patient, and my physician certainly doesn't have time to see me that many times. So is there a way that we don't diminish the overall quality of care, but we supplement the laying on of hands, the face-to-face, that moment where you grab the handle as you're walking out the door and say, oh, one more thing. Mm-hmm. How do we do that in a way that's supplementary with telehealth services?
Before we go too far away from the public health emergency, I believe part of it was a relaxation of enforcement around HIMSS. When the public health emergency ends, is that automatically going to get us back to where we were in terms of, HIPAA, in terms of HIPAA?
Right. No, I mean, I think this gets to another issue. And, this is the great thing about doing your radio show or your podcast. We're in the modern era. That's always interesting is there's so many threads to pull. HIPAA, as every single one of your listeners knows, is one of the most often miscorrectly quoted or incorrectly cited regulatory elements that exists on the face of the earth. The number of conversations I've had with people where they're like, well, HIPAA, and it's just,
Yep.
I always have to start with the basics. Are you a covered entity? Are you a business associate? And the problem, the situation that we're looking at right now with HIPAA is some of HIPAA would return. But I think the larger question that needs to be answered in Congress is, in fact, slowly, hopefully grinding towards something that looks a bit more like a comprehensive privacy bill so that the elements that are concerning are captured by some other part of the law. Right now, what happens if you're not a covered entity or not a business associate, then you actually really aren't under the purview of HHS at all in the Office of Civil Rights. Any personal health information that isn't held by one of those two, or there isn't an agreement from that, is actually handled by the Federal Trade Commission. And the Federal Trade Commission doesn't even have all of its commissioners and may not for another length of time. So we are really looking for Congress to kind of correct that. And it's clear you got HIMSS on your mind, but that does get to something that was interesting that comes out of HIMSS and all of the other issues is that as we're moving forward on greater data portability, and you and I talked earlier about TEFCA and all these concepts, you're exactly right that all of this patient-generated health data is going to find itself in a situation where folks in the healthcare industry who are part of a covered entity or who are at a business associate are going to have to figure out, how do I share? What do I share? What am I required to share? And how do I do it in a way that doesn't get me crosswise with the Office of Civil Rights? And on the flip side, patients rightfully are saying to us in the healthcare industry, where is my data? It's mine. I want access to it. So yeah, the parts of HIPAA that are impacted by all of this, they will come online, but you're asking a much bigger question, which is, are we going to right-size HIPAA or right-size privacy laws to make sense in the modern data era?
You mentioned some of the things that were in the Omnibus spending bill that passed. Were these things that relate to the public health emergency and telehealth and those kind of things, were they planned to be in that bill all along, or were they just kind of slipped in? In ancient history, if we go back to when the High-Tech Act was passed, it was during a time when the banks of the world were collapsing, and it just kind of got stuck in there. Go ahead.
So, again, great question. Essentially, it boils down to, what's that old line? Never let a crisis go to waste.
Yes.
And so, omnibus spending bills are a place where, because Congress has to get them done, it's often a place that you go to look to put in absolutely desperately needed policy requirements at the time. Plus, the reality is that Congress wasn't sure it was going to pass anything else. And the idea of our entire telehealth, COVID treatment, remote patient monitoring all just go poof up in a cloud of smoke on April was frankly untenable. And I think there would have been pitchforks and torches at the offices of members of the Senate and the House if they had failed to do this, because, and frankly, not from caregivers, but from patients saying, what do you mean I can't do this? What do you mean my doctor won't be able to see me because there's no reimbursement code for it because of 1834M? I mean, explaining 1834M restrictions to a patient, it's hard enough for those of us who get, combat pay to understand it.
Exactly.
Much less for a general patient.
Well, before I hop to another topic, I'm going to ask you about, let me mention to those listeners that we have that are just joining. You're listening to a special series of the Tate Chronicles with my co-host, Morgan Reed of the Connected Health Initiative. There were a couple of things that I believe came out of the White House a week or two ago. Maybe I've got it wrong, but one thing it seems is that as of yesterday, 3/22, there's no longer federal reimbursement for providers for folks uninsured for COVID testing and treatments. Have I got that right?
I have not paid enough attention to that element. My wife might know.
Yeah. I'm pretty sure that's true. I saw it.
I believe you.
And so
I've been so focused on the telemedicine side of all of this that I haven't. But it does get to a key point. Look at how much reimbursement drives behavior and the way that loss of reimbursement can really mess with things.
Out of the blue, companies started up to basically put a tent on the main road and start doing testing. And if they gathered the right data, they were being reimbursed. Of course, it was only for the uninsured. But along with that, I believe as of right now, April 5th, there's no longer going to be reimbursement for vaccinations.
I mean, this seems crazy. This is my personal opinion, not CHI's opinion. But inside of the healthcare world, where we've watched so many nurses and so many physicians leave the care, the part of what they do, walk away from it through this pandemic because of the stress of it all, because of what's going on. And the idea that we would somehow find ourselves where the people most likely to be out and about, not working from home in their cloistered office, are no longer going to be covered. It seems, it does worry me a little bit that we're begging for yet another pandemic. And I don't know about you, Jim, but I can't take another round of another Omni, whatever, B2, B3, B4. I'm pretty sure that almost every single one of your listeners is going to say the same thing, which is, I need a COVID break. I need us to get on the top side of this wave and not be buried. Sorry.
It's almost exactly, this week is 2 years to the week that everything shut down. And so hopefully we are slowly coming out of this global pandemic. Hopefully, there's been some lessons learned and some lessons not learned. I know one thing that's been learned is that all this technology, telehealth is part of it, that was kind of sitting on the shelf, was taken off the shelf, and everybody figured out how to use it really quickly.
We've all known, every single patient, every single provider has known that used correctly, there are elements of the supercomputer in your pocket, that smartphone that you've got in your pocket that's way more powerful than what it took to get the space shuttle into space, could actually help us, either by helping us collect data, helping with patient engagement, heck, medication reminders, right? Your phone nagging you to take your meds. There were a million little ways in which this device would be helpful, and it was really the problem of reimbursement that was holding it back. So you're exactly right, and your characterization of taking stuff off the shelf is really critical, because a huge part of it was good care was being sidelined by bad policy.
Yes, it was.
And that's the real issue, right? It wasn't, nobody had to go to the secret laboratories and invent a bunch of new stuff. People whipped out their smartphone and say, I wonder if I could talk to my physician with a camera on, and we could have my visit that I need to have for my therapy. Or, this is the kind of thing that really moved forward. And so that was a big part of it.
It was a real shift. Even if the reimbursement was there for providers, individuals were forced to use telehealth.
Yes, exactly. Behavior change. Yeah, exactly.
And it happened, and it happened much more successfully and quickly than I could have possibly imagined. It was something to live through. Now, that's kind of a good
something
thing.
To live through. Yeah. Jim's phrase for the day, something to live through.
Well,
it's true.
Yeah, there's something else, Morgan. I think that, I don't know if a lesson has been learned, but something's been experienced. and that the electronic healthcare system had difficulty getting clean, good data on the pandemic so that appropriate policies could be done, could be chosen and a direction. We didn't really know how many people have been vaccinated. We hear 100,000 people a day were testing positive, but that could just been, we don't know really what that meant. It just meant that maybe a lot more people were scared and being tested. If people, have them test positive twice, 2 months apart, were they counted as one person or two people? It varied. And so, I hope if this ever happens again, we're more prepared to do policy based on more discrete, I don't know if discrete is the right word, but more actionable data.
So that's an important point you make. I always think of a difference between data and information, right? So a big part of what needs to be done, there are two things. We also have a phrase in the tech industry, you say garbage in, garbage out. Oh, yeah. Meaning if the data that you start with is not any good or not accurate or unintelligible or not workable, it doesn't matter how much you massage it, it's still terrible, right? It doesn't help you. You see this in healthcare all the time. If the cohort that was being tested didn't match the cohort of the population that's going to take the medication, then you can get these results where, well, it worked fine on that one group, but it didn't include the people who were actually most likely to be taking the medication. Same thing goes for here, as you point out, is this, how do you differentiate between the same person getting tested every day versus 5 different people? And how do we know on all of these elements? So there's 2 things that are going on that I think will help this over time. One of which is, I think the states all got a lot better on their data management practices, again, under fire, because they were having to show it in order to make sure they were getting money. And nothing helps to sharpen up the pencils with the green eye shades more than the idea of reimbursement money. So you saw some better data sets coming out of the governments. The second part is the ongoing, albeit a little slow and still fighting through it, effort by the Office of National Coordinator out of HHS around interoperability and in the confines of electronic health records. Improving the kind of data that's in your EHR, electronic health records, improving access, improving what we term as APIs and availability for third parties to access those APIs in a safe, secure manner. All of that will help us to comb through the data and find either interesting facts or oftentimes find places where the data is just absolute crap and go tell people to go back to the drawing board. So I'd say there's 2 things. Money and policy change are both helping us slowly get to better data sets that more reflect the real population here in America who needs care.
Morgan, I'm kind of sad to say it, but we're almost totally out of time. I can't believe how quickly time has flown by. We may need to extend our talking window in future months. But first, let me say, if listeners want some more information, and there's a lot available at the Connected Health Initiative, they can go to connectedhi.com. That's connectedhi.com. And to our audience, thanks for tuning in to this second of this series looking at policies impacting connected health technologies. And a salute to you, Morgan, for coming on board as my co-host for this series.
Jim, it's been great, and don't let us forget, we should talk about a couple of other things in that FY appropriations bill.
Yes.
That I think will be good for patients, not just for people, regular people, not just those of us in the healthcare industry.
Oh, that's good. I'm looking forward to next month's episode. You can find more information on this show's program page at Healthcare Now Radio. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors. See you next month.
Tate Chronicles transmission ending now.